So thank you very much, everybody, for joining today for the next session of Oncology Beyond the Obvious. As you know, this is a special webinar, and we are really appreciative that people of the stature of Kumar and Ullas are appreciating the hard work that we have put in. Really, it is intensive work because we identify a landmark paper or a paper that could be landmark, and then over 1.5 hours try and discuss threadbare each and every aspect of it. And as you know, it is divided into 3 parts. The first is the interview, the second is the panel discussion, and then the expert part. So today for the interview, we have none other than Dr. Kumar Prabhash. But my job is to introduce Dr. Amish Vora, who is really the person who is doing all the hard work behind this entire session. And Amish, I think it is because of your preparation and your rehearsal and your diligence in identifying the right questions that make a difference to how useful it is in the real world to our colleagues. So Amish, with those kind words, it's over to you,
please. Thank you so much, sir. Really happy that my mentor and my sir is appreciating me. Parikh sir जब appreciate करते तो दिल बागबान हो जाता है. Thank you so much, sir. But as you know that without your support, guidance, nothing is possible. And at this point of time, I would also like to congratulate Kavina Creations. Ullas, I know this is not the place where I should be saying, must say that we wanted OBTO to be away from any of the influences. And I remember Kavina Creations first time told me, sir, paisa koi tension mat lo. If you are doing a good work, you continue and we are with you. So I think that is, really motivates person. With that, today we are discussing ADAURA study. Can I have the next slide, please? So everyone knows New England Journal of Medicine, October 29, 2020. This was published. Osimertinib in resected EGFR mutated non-small cell lung cancer. Next slide, please. The study design was very straightforward. Stage 1B, 2, 3A, NSCLC, non-squamous NSCLC, with or without adjuvant chemotherapy. Chemotherapy, whether to give or not, was at the discretion of treating physician. Of course, above 18 years of age, good performance status, there has to be compulsorily either exon 19 or 21 mutation in the EGFR. Randomization, if you have given chemotherapy, should have been over and patient should be randomized within 26 weeks after surgery. And if you are not giving chemotherapy, within 10 weeks. Patients were randomized into 1:1 fashion in Osimertinib 80 milligram once a day for 3 years versus placebo of same kind for 3 years. Disease recurrence or disease-free survival was the main primary endpoint. And that is what we have seen. Next slide, please. Very female predominance, as we all would have expected in EGFR, smokers and non-smokers, both were included. Obviously, Asian patients were much more compared to non-Asians. Next slide, please. Equal distribution of stage 1B, 2, and 3A. Majority were obviously adenocarcinomas. Next slide, please. This was, again, as I said, N0, N1, and N2 were equally distributed. Surgery based on the surgical institute and the surgeon. There was almost similar preponderance of exon 19 and 21, 55 and 45. Adjuvant chemotherapy was not given in 40% of the patients. Next slide, please. This was an unique, unplanned interim analysis. Did happen between 2015 and 2019. By that time, all the patients were enrolled. January 2020, there was an unplanned analysis based on very high efficacy noticed by various centers, but there was 33% maturity. Next slide, please. Hazard ratio of 0.70 and less would have been a positive study. The hazard ratio entire population was 0.20. and the hazard ratio in stage 2 and stage 3A was 0.17. Only stage 3A hazard 1.2. Ullas, you will have to answer in your panel discussion. Less than 0.12 कौन सी study में देखा है? नहीं बोलोगे तो Google करना पड़ेगा. Next slide, please. Okay. The forest plot chart, the important point which I wanted to share, whether you have exon 19 or 21 did not make any difference. Whether you gave adjuvant chemotherapy or not gave adjuvant chemotherapy, again, did not make any difference. Now, this opens up a Pandora's box and we will tax our brain for that. Next slide, please. Of course, Osimertinib rahega to CNS metastasis mein there would be a difference in the pattern. Next slide, please. It was a quite well-tolerated drug, as you see. Next, so it was, grade 3 is hardly 0.101% of patients. Next slide, please. As a result of these, December 18, 2020, US FDA approved this drug in this indication. So we can close the presentation. This was the gist of the ADAURA study. And now we come to today's interview. Kumar sir, Parikh sir, would you introduce? Nobody, I think there is no naive person who doesn't know Kumar still.
It is a privilege to introduce Kumar Prabhash because he has achieved so many things. And right now, as head of Department of Medical Oncology at Tata Hospital, he is in a position to help the medical oncology community far and wide. His power, I should say, extends beyond the national boundaries of India. And he is considered as a world authority on several aspects, especially on lung cancer. And we are now discussing lung cancer, so it is highly appropriate that we have the interviewee as Dr. Kumar Prabhash, and it is my privilege, thanks to Amish, to introduce him to you. Over to you, Amish.
Thank you, sir. In addition to that, I would say a few things about Kumar very quickly. Kumar and I joined Tata Hospital together. And I remember Kumar is one person who initial stages, and even now I'm sure he must be doing, he went to the lab himself, spent hours and hours to see there. He spent time, lot of time with data. He spent a lot of time in devising the protocols, discussing. And as a result, we know that today, anywhere in the world we stand, the Tata Hospital data is something far superior, is something which we are proud of. And this is lot of hard work and dedication by Kumar. Kumar, I really, whenever your name comes, it's really with great pride, I think of you. There was one instance where Rajiv Gandhi there was a conference, and I'm sure Ullas must have orchestrated that. Ullas was sitting, that was orchestrated. Kumar was being felicitated, wo chaddar baddar chadha rahe the, usko shawl pehna rahe the, and I was sitting in this audience and I said, wow. And then you start thinking and you really feel that he deserves every accolade which he gets. Kumar, keep doing the good work. Really proud of you, and thank you so much for being on this platform.
Thank you, Dr. Amish and Parikh sir. And as you said, Amish, he has been our mentor, and in fact, he is the person who chose me for TMH, and extremely grateful to him, and so nice to hear kind words from colleagues. Thank you so much.
Okay, Kumar. We will, the first tradition of OBTO when we start the interview is to ask few rapid fire questions. And these rapid fire questions require rapid answers. Okay. So we are not talking of stage 4 lung cancer today. We are talking of anything but stage 4. So all my questions are directed towards the stage 1B, stage 2, stage 3A, and maybe stage 3B also. So in your practice, what is the distribution of these stages out of 100 patients, Kumar?
So out of 100 patients, if we take stage 1, 2, and 3, then the distribution for stage 1 remains around 15%. 2 around 15%, and 3 around 15 to 20%, and rest is around 50% will be stage 4. If we take around only stage 1, 2, 3, then the distribution in our practice remains around 10% stage 1, 15% will be stage 2, and rest will be stage 3. In these stage 1, 2, 3, if we take only them as a number.
Excellent. But I'm really happy to hear that 15% of patients are diagnosed in stage 1. So that means our screening methods are working well.
No.
That's great. So, Kumar, do you do? Sorry.
Can I comment on that? So
go ahead.
So this is our hospital-based registry data, and I do agree. I know your comment on that. Is it really true? There is a 2 aspect to it. One aspect is the staging part, but that's in the hospital registry data, and that was similar data when we did one prospective collection of data in our hospital, and that was one of our first publication for the kind of smokers and non-smokers. If you read the first paper of non-smoker of 40% was from our group, and that was the paper where also we had stage distribution. But one of the key issue remains, then why only 5% people get surgery done? So that's an important question to ask, that in spite of this is the number for stage 1, 2, and 3 in our population. And that I don't have a definitive answer to.
No issues. Thank you for the honest answer. Kumar, EGFR mutation study in all comers or only in stage 4 lung cancer you are doing?
So we are doing at this moment in all comers EGFR study. We used to do for stage 4 only, but today all comers.
That's great. Good to know that irrespective of the stage you have started doing, and that is, you started putting the leave of ADAURA study. Thank you for that. Kumar, Port C randomized controlled trial.
Can I explain a bit? I know that the connotation is not that. Connotation was quickly 10 seconds. So we were doing, because when you have this stage 1, 2, 3 patient relapsing, and if you don't have molecular data at that time, you used to get stuck with few weeks of a report not available. And we have good number of patients where we have started patient relapsing within 1 day of their coming to the hospital, just because the molecular data was there and tissue was in good shape when you did the test. If the patient relapsed after 3 years, you may not get a molecular test done from the older blocks. So reasonings are different. So I didn't have any hint about our ADAURA data before the data.
Kumar, Port C randomized control trial, post-op, end-to disease, RT versus no RT. Finally, have we stopped giving RT in these patients, or you still continue to practice post-op radiotherapy in end-to disease?
After those 2 randomized trials, yes, we have stopped it. We don't give it now.
You don't give it anymore. That's good. So at least one thing is crystal clear, and there is no argument about that. Patients of stage 1B, 2, and 3A above 4 centimeter and above, do you give chemotherapy to all your patients, or you have selective for chemotherapy?
We try giving. We are able to deliver in 70%. But yes, we try giving in all patients, but because of various issues, we are not able to deliver 30%.
70% of patients do receive chemotherapy, and as I presented in NEJM, 60% of patients did receive chemotherapy there also, 40%, but majority of those were 1B actually. Yes. So I think it is coming close to what you are practicing. Kumar, what is your relapse rate, stage 1B, stage 2, and stage 3A?
So stage 1B, around 40%, stage 2B and stage 2 and 3 together, all more than 70%. They do relapse in long term.
More than 70%. So Kumar, yes. Today we are discussing the patient at risk. That means that for 20 to 25% of patients who will not relapse, we are doing surgery in 7 to 75%. Extra patients who would have anyway relapsed. In your clinical practice, Kumar, do you think that there are certain patients who always relapse versus certain patients who don't relapse?
Yes, I won't say in clinical practice, but just to get a hang of it, one of the reasons why most of the surgeons, they won't do surgery for multi-station N2 is not that they can't do surgery. There may be 1 to 2 centimeter lesion multi-station, because majority of them, they do relapse. And that's the reason they do get concerned. So a hint about it, where majority of the patients, they do relapse.
Okay. That's a very, very important point, Kumar, and this can come only from you. Thank you for this. This sets up the
Can I share the data for audience if the students are there?
Yes, please. Yes, please.
N2 disease, when the studies were done before PET-CT era, it is very interesting. 2 studies done, one of them in NAGM. In the surgery arm, the curve hit the baseline, meaning after a few years, there were not a single patient alive in that trial. And that was a bit strange, but that's true. And that is why N2 disease, you will see so many controversies. Should we do aggressive surgery or not? But that was pre-PET-CT era.
Very, very interesting, Kumar. That tells us selection of patient, right time, right place, and by right surgeon is very important. So let's come to ADAURA study today, what we are discussing. Kumar, in the discussion part of NEJM, the third line from above says that 90% of patients in Osimertinib arm, as compared to 44 in placebo arm, are alive and disease-free at the end of 2 years. After this statement, I think there is no doubt in the people's mind, but I would still ask you upfront before interview, do you think this is practice-changing data? Right now, just say yes or no, and then in the end, again, we'll discuss.
Yes, it is practice-changing.
Yes, it is practice-changing. Okay, so now let's come to the trial design of ADAURA study. I have 3 main concerns in the trial design, Kumar. Your opinion. First of all, it was a placebo-controlled trial. We have data of DFS with erlotinib and geftinib. Okay, in the adjuvant setting, and we know that the DFS data exists. In fact, one of the earlier geftinib data has hazard ratio of 0.17, exactly to that, but OS did not mature to live up to the expectation. Is it right to do placebo rather than doing either geftinib or erlotinib as the control arm? Especially my second point is when the trial was not powered for overall survival advantage in adjuvant setting. Kumar, your opinion.
So there are 2 aspects, this question. One is, and that's a bit easier one, that what is in the community about the practice when you design a study, that if majority of the clinicians, they are giving geftinib, then I think so there should be, there needs to be a concern that we don't have that treatment in the standard arm. Today also, in spite of geftinib available for almost every patient in India, a majority of the clinicians don't practice giving this in adjuvant setting. And that was the worldwide practice at that time also. Second part, that is based on what data is available. So you do have data, I do agree with that, especially initial one when EGFR mutation was not done, and we had those studies like BR19, Radiant. There was negative study, but subgroup looks like could be positive. CTOM was positive. But there was an issue regarding those studies, and I'll come to one more after this. How did the standard arm fare? That is one part of it. And then second, what was the difference? Not the quantum of difference was like this. And second part, standard arm, that there was the issue regarding how the curve behaved. And it is what is thought that the way the staging and other things was done could be, there are a good number of patients who came who already had advanced disease, and that's why the benefit of DFS is being seen, which we already know, and we call it DFS. Maybe it was a PFS. There was another study in Japanese group where in geftinib versus chemotherapy, and most of the trial were geftinib versus chemotherapy, the geftinib arm, the DFS benefit also was not there. So there was issues with Gefitinib and Erlotinib as a standard treatment in this setting. And I think so it has been fair to not to have it, but I agree that this is one of those criticisms should remain with the study.
Especially like in India, if the control arm would have been in Gefitinib, at least we would have known the quantum of improvement with Gefitinib in a randomized control fashion. But I agree with you, that was not this thing. Just quickly, 3 years of Osimertinib. Why not 2 years? Why not 5 years? Is there any science behind it which I don't know?
So I think so. Only a bit of a science that 2 years of Gefitinib. There's a concern that in one trial the DFS was not beneficial, and in other studies looks like patients starting failing. So maybe a bit of a science, but I think so this was relatively arbitrary, and that concern does remain. That longer you give, disease control remains better. It is not looks like a sidle drug. So let's see what happens after 3 years. But I totally agree. This is fairly arbitrary, and that's why after 3 years we need to be careful what happens, or maybe you suppress it for longer period. Maybe those tumor cells goes into quiescence and it doesn't come back. But again, a bit arbitrary.
Okay, cool. We have a lot of points to cover, and I still want to ask you a lot of questions. So very quickly we'll cover unplanned analysis in a phase 3 control trial. February 2022 was the data to be matured, and January 2020 unblinding was done 2 years before. Only 33% maturity when there were already 61% of the patients in Osimertinib arm was Osimertinib. Do you think that this unplanned analysis helps in medicine, or this was a bit too early?
So as far as the trials are concerned, and doing some of them myself, this becomes a painful subject. But as far as the ethics of running of the trial is concerned, and you have an independent data safety monitoring committee, the question would have been valid. Think about if this kind of benefit was seen after the full planned analysis, why there was no interim analysis. So as far as ethics is concerned, there was an independent body who decided, and in spite of that, you had a data which is positive. So I think so that was a fair way of doing. So they did go for patient safety, and in spite of that, they got a positive study. So that was a fair way of doing.
So you feel that it was good that it was unblinded, but Kumar, again, there is no comment required for this, but you remember that the company, the sponsor did not say anything ki kya hoga iske baad, whether there would be a crossover, whether they would continue the study. There was a lot of hue and cry, and after they said ki yes, we are continuing the study, and that you and I, both of us are aware. Kumar, the study results were, something hazard ratio and DFS was absolutely spellbound. And, we know I presented that in this slides. Pattern of relapse, we will talk about that little later. But in adjuvant setting, DFS, primary endpoint, and OS not even planned. Are you okay with that?
No, I usually am not okay with that. OS as one of those analyses to be planned should be there. And, it is there. I do agree it is not powered for it. That is an issue here. But OS as a secondary endpoint is there. So it being as a part of the trial, it is important in this setting. So OS is important.
OS is important. And then if 2 questions, there are 2 scenarios. OS not being significant at the end of 5 years and OS being significant at the end of 5 years. Would your thought process about this study results change hazard ratio of 0.12 in stage 3A, Kumar?
It will. It will. The way I counsel my patient will change. If OS analysis is there, OS benefit is there, then my counseling will be a bit different from OS benefit not being there. But question is that, will I counsel this as one of the option for the patient, considering the hazard ratio I know about the patient for DFS today being there? Yes, that I think so. I will always consider in counseling the patient, but counseling pattern will be different.
But Kumar, I remember when we were rehearsing for this, you gave an example, and I really believe if a patient has to live for say 6 years, 4 years without the disease and the end of that, and relapsing within 2 years and then living for 4 years, so OS remaining again 6, living without disease, isn't it important? Why are we ignoring that fact?
I do agree with you, and I totally agree with you. Let me make it a bit more starking. If we have 5 years or 6 years, 5 years without disease and 5 years with disease, meaning that only 1 year without disease. So there's no doubt for me that living without disease is important, and we all have seen in our patients management that it is important. But I also do agree with the people that there are a group of people, not all of them, there are a group of people for whom OS does become important. Because when I do counsel, I do realize some of the patients do want this data to be there. So, but living without disease is an important endpoint. The issue will be living 3 years without disease and living 2.5 years without disease. Now, that is a totally separate issue. But living 4 years without disease and living 1 year without disease is different.
I agree. There's a never-ending this thing. Do you think, Kumar, that the relapse pattern will change after ADAURA study?
Looks like there is a good hint that there is a bit of a change. One is definitely CNS, and that is all talked about a lot, that CNS control is far better. Another pattern is that systemic disease control is far better. And local regional means in the thorax, the relapse in thorax are far commoner as compared to placebo arm. So looks like the pattern, there is a difference in the relapse pattern for the disease if osimertinib is being given.
Right, and we need to yet see that whether these relapse would be asymptomatic, symptomatic, heavily loaded, non-heavily loaded. I think that also will define our practice, what I feel. Kumar, one of the most important question for you.
Can I add?
Chemotherapy versus...
Can I add 10 seconds?
Please, go ahead.
So one part I missed, one of the issues will be there for DFS and OS will be the toxicity, which always comes into the play when we want to discuss the patient for treatment. So which I missed. Go ahead, please.
Yeah, so grade 3 toxicity was much less, 0 to 1%, as I showed that. And osimertinib, we all know in our practices, sort of tolerated quite well. My main question to you is the chemotherapy. There are two aspects which I read in this paper. Forest plot chart says that whether you give chemo or not, chemo doesn't matter. Okay. The hazard ratio with chemotherapy was 0.23 and hazard ratio without chemotherapy was 0.17 or 0.12. There was one supplement. They said that the chemotherapy arm with EGFR positive did poorly compared to chemotherapy without EGFR when they compared. Do you really think that this trial says that if EGFR exon 19 or 21 positive, it is okay if you don't give chemotherapy? Kumar, this is very, very important. I feel this is a second practice changing statement, which whether are we allowed to make based on this study?
So I think so. There was a second paper regarding chemotherapy used in this setting. And then what we need to look into it, that in stage 2-3 as a separate group, when you have given chemotherapy and then what is the hazard ratio, and stage 1B separately, what is the hazard ratio? Because we do know in stage 1B the hazard ratio is on the higher side. And it looks like it is similar. I won't get into detail because the differences are very little. But what does it mean? That patient who received chemotherapy, there was an added advantage as compared to what you have achieved with the chemotherapy. What do we know about chemotherapy? What do we know about chemotherapy that till today, that chemotherapy does add life to the patient, which we don't know about osimertinib at this moment. Second part, the chemotherapy impact in the lung cancer differs from stage to stage. So if you have a stage 1B patient, the absolute survival benefit is 1.6%. In a stage 3 patient, the absolute improvement in survival is around 13 to 14%. If you take N2 disease separately, for which there are 2 randomized trials, absolute improvement in survival is around 20%. And these are documented in various randomized trials and also many retrospective study by SEER data that chemotherapy given, it adds life to the patient. So at this moment, it is important that where the patient requires chemotherapy, it is given. And yes, there has to be a separate study which suggests that we can skip it. One important thing to remember, all Gefitinib trial, or many of them, not all of them, it was compared Gefitinib versus chemotherapy. And that is one of the criticism of those studies, that did they do the right thing? What would have been the result if it was given after chemotherapy? So in today's time, chemotherapy, if needs to be given, it is important to give it.
So my is, and that is assuming overall survival shows significant difference. And forest plot chart says chemo or no chemo does not make any difference. Would you still require a new data or the new RCT, or you would stop using chemotherapy?
So if OS shows a difference, this is again in chemotherapy arm, above what they have achieved with chemotherapy. It won't be easy, but I do concede if I have a 70-year-old patient with 4.1 centimeter lesion, and the absolute survival benefit, what I have learned, is around 1.6%. My response will be different. Then if you have a T3N2 disease and a 50-year-old, my response will be a bit different. But I will not be changing the chemotherapy practice in haste, because that has been there for 3 decades almost now. Or for at least for 2 decades now. And looks like that has worked everywhere.
Okay, Tarini agrees with every word what you are saying, and I can see in his chat box. Kumar, the last question, and this is again extremely important for all of us, because whatever Dr. Kumar Prabhash practices, we love to follow that. If a patient of stage 1B, I am leaving, stage 2, stage 3A, non-small cell, non-squamous, properly resected patient comes to you with either 19 or 21 mutation positive, patient can afford Osimertinib. Today, without OS data, would you give Osimertinib or not?
I will definitely counsel, and I believe that if I don't counsel, then I think so I fail in my duty. I will put it this way, because while counseling, I have realized some patients don't want it, and that is fine. And then you realize, yes, there are aspects which a patient wants to have more information. But counseling for this treatment, yes, I think so that needs to be done.
And if the patient says yes, you will go ahead and give 3 years of Osimertinib to this patient.
Yes, that is true.
Great. Kumar, I am done with the interview. The final parting comment, if you have any, otherwise Ullas is, we are waiting for Ullas to talk. Any final comment on ADAURA study if you have, otherwise over to Parikh sir. Thank you so much, Kumar.
Thank you, Amish. And I think so for me, there's a lot of learning how studies can be done, the way it was designed, the way they were, some aspects which you pointed out. Only PET CT not being done; those patients were included. In these patients, MRI was not must, which was that's what we need to learn, how pragmatically we need to criticize for those for this study, no doubt about it, but also learn that how a good study can be done pragmatically if things are not there in many of the places. That is something important to learn. Thank you.
Thank you very much. Thank you very much, Kumar. Thank you very much, Amish. Kumar, your last sentence of being pragmatic, even in the context of a prospective randomized clinical trial, is a very important take-home message. And I think all of us will learn greatly from that. Now we move on to the next part of today's program, and that is the panel discussion. We have none other than the debonair Dr. Ullas Batra, who is going to moderate this. And we have a galaxy of panelists with immense experience in lung cancer management. And Dr. Prasad Narayanan from Bangalore, Dr. Bhavesh Parikh from Ahmedabad, Dr. Kumar Prabhash will join the panel, Dr. Sudeep Shrestha from Nepal. So we have an overseas expert with us this time. Dr. Nitesh Rohati from Delhi, Dr. Govind Babu also from Bangalore, Dr. K.P. Sahu from Bhopal, and Dr. Mohammad Rafiq Islam from Bangladesh. With these few words, Ullas, without eating into your time, I hand it over to you.
Thank you, sir. Both Dr. Sahu
Before Ullas, can I say something, Ullas?
Yes, Dr. Amish. Just remember that the program is being recorded.
Parikh sir and everybody else, 3 days back, there was a company person who was talking to me about Selpercatinib, and she asked that, sir, who will have the highest number of patients? I said, nahi, mujhe nahi pata. But of course, UB, UB kaun hai? नहीं बोलते सर यूबी मतलब यूबी कौन है फिर उसको पता चला यूबीटीजी उल्लास बत्रा द ग्रेट मैं बोला ऐसा बोलो ना with that over to you Ullas.
Thank you Dr. Amish. I was not when you asked me whether I want to be interviewed
meeting પાછું 2 મિનિટમાં તને ફોન કરું પાછો
બિલકુલ ફોન કરી પાછો
Dr. Bhavesh, we will not phone karo pacho for next 45 minutes. We also heard the money transactions which was going on. And Dr. Amish, the only reason why I refused to be interviewed was that I didn't want to be roasted by you, and you're actually roasting me. Okay, let me start. So I have been asked to do a very difficult task of doing a panel discussion on the ADAURA trial. Difficult because I'm going to do it after Amish and Kumar have discussed threadbare about that trial. And my first reactions, as I usually put my talks on the ADAURA trial, the panel discussion, and when I first saw the data of ADAURA trial, I was like this. I mean, this was like Osimertinib in the adjuvant setting, and that was like a fantastic going on for 4. And then I started reading and researching and searching, and this is what I thought we were actually coming down into. And I'm sure there are going to be people on the left side and people on the right side. And my subsequent reactions actually believe there's a difference between the perception and reality. So Amish, how many are there? 3 or 4? The 6. So it's a matter of perception. Some people will say 4, some people will say 3, Sahu will say 7. So that's a different story altogether. Bhavesh Bhai will say it doesn't make a difference. It is $700 ready to be counted over there. But actually there are 2 sides to every story. And somewhere in the middle lies the truth. And that is what we are going to search for, the truth about the ADAURA study today. So let's start with the panel.
Ullas, there are 3 sides to a story.
Sir, I have to learn. I have to do my DM again, sir.
No. Okay, go on.
Okay. So I will do that, sir. And please don't make the same comment again, sir. I mean.
No.
Okay. Okay. So let me start with even Dr. Govind Babu only. Sir, we have spent 30 minutes having people of stature of Amish and Kumar discuss about ADAURA. Kumar said 10% of people, 15% of people in stage 1 disease, 5% of them undergo surgery in stage 1, 2, and only 30% of them will have a EGFR mutation. Is the issue even relevant, sir, into your clinical practice? Dr. Govind Babu, sir.
Yeah, definitely it is relevant.
Okay.
So as you heard, 2 people talking about ADAURA. So you heard only 2 sides of the story. Like I said, there are 3 sides to every story. Okay. One is the side which was being interviewed, the interviewer, and the truth in between. So you need to find out what the truth is.
Okay. No, sir, but in your clinical practice, how many patients have you really got of a stage 1 with an EGFR mutant? I mean, that is what I wanted to,
I've had only 1 because this patient was incidentally detected post-COVID.
Okay.
So we have very few stage 1, as you see. And for these early stage stages, 1, 2, we were not even looking for EGFR till all this data came. Okay. Unlike what Kumar was doing.
Okay. Dr. Bhavesh Parikh?
So the issue is 100% relevant, and practically even in Ahmedabad, very few stage 1 patients, and at present we are not doing in stage 1 EGFR testing.
Okay. So Dr. Amish is asking me, stage 1, 2, 3. Yes, I'm putting all these things. So what I'm saying is ADAURA trial, how many patients of your lung cancer undergo surgery, and how many of them get tested, and how many of them will be candidates for Osimertinib? That's what I'm asking. So Dr. Sahu, the Prince of Bhopal.
Yeah. See, to come to a topic, is it relevant? Yes. Do I have a lot of patients? I can tell you that I've seen only 3 lung cancer patients operated in the last year. So it is not a very common thing in my practice, but yes, one would love to have that and have the knowledge to give the best advice to the patient, even if it is for one patient.
Okay. So my the terms when I thought about this question were numerical in the terms of patient. We may not all have great number of patients, but scientifically, you know, I mean, to me, the major concern basically was in the terms of drug approvals, the clinical trial design, the conducts, and the interpretation of the modern era. I think that's very, very important that we do discuss and we are not taken for a ride by all the big pharmas and big companies. And, you know, so that is why to me, ADAURA trial was actually a practice changing. You know, you have a 0.17 HR and still we are debating whether the thing will be there, the DFS and the OS. So that's very, very important as far as I am actually concerned. So to me, the issue is definitely very, very relevant actually. So let's start with the standards of care pre-ADAURA. So let's see, ADAURA came in 2020. So let's say what were we doing pre-ADAURA? And, you know, this is the trial of Radiant, which was basically, you know, there was adjuvant erlotinib versus placebo. And if you can again see in the EGFR mutation, the DFS was fantastic. The HR was very, very significant, but this was a subgroup analysis. This was not a planned analysis actually. There was another study, which was the SELECT study, which was talking about, which Amish was talking about. But again, this was a single arm phase 2 study. DFS was again seen in this. It gave info about how do you treat a relapse. People who got erlotinib, stopped erlotinib after 2 years, relapsed. 26 of them got a rebiopsy done. They were again treated with erlotinib and they had the best actually survival at which came, and they were the people who were responding. So a very important question, which I will ask you later, is whether people with Osimertinib, when they progress, what do you do? So this trial actually showed that you can give adjuvant erlotinib, give it for 2 years, stop. When the disease relapse, you can actually go ahead and give them erlotinib once again. This is the most important adjuvant study design, which was comparing gefitinib versus venetoclax cisplatin. This was the DFS curve. This was the OS curve. Again, there was no significant DFS and OS advantage. The DFS advantage also trickled down and became numerically, p-value was insignificant, and there were high rates of CNS recurrence. So let me start with Nitesh. These were the 3 major trials which were going on. So Nitesh, what was your practice, you know, at the time pre-ADAURA? Were you giving gefitinib prior to the results?
No, I was not.
You were
no,
not.
I was not. I was not. And I think it comes back to the question which is still being addressed. We did not know whether catch-up EGFR treatment was better or whether treating the whole population was better. And that's why it was better to wait. But I accept I had a population which I could watch very carefully. So if there was even a doubt that there's a group which can't be watched as a population, I think adjuvant would become a better option for that.
So your main concern, Nitesh, if I have to put in a single term, was the DFS versus the OS debate, or what was one concern that you had?
It was DFS versus OS. I still was not convinced that the OS would be better if I would delay therapy to recurrence in the population, majority of population which would recur actually. I mean, we're talking about 70%, 80% patients recur of the at least stage 3 group.
Prasad?
Yeah, I agree with Nitesh actually. I never gave adjuvant gefitinib and the same reason as Nitesh said.
Okay. Dr. Sudeep?
Yeah, actually, as you said, am I audible?
Yes, sir, you are.
Yeah. Occasionally, I gave it because the reason that I gave it was we could see there's a lot of relapses after the surgery, and these people are staying away, and the follow-up was bad. And I have like a sixth sense that since the EGFR, this TKI were so good in metastatic setup, they should also do work in metastatic setup. Fair enough. In some occasion I have tried, but when I found this ADAURA trial, I was happy that at least not gefitinib, at least this was working. So sixth sense, I was in the impression that this should work somewhere.
So, fair enough. Dr. Sahu? Sir, gefitinib, 5,000 rupees, what was the harm in giving?
Yeah, so I'll be very honest. See, the thing that has happened in the last 5 years is a thought change in all of us. If you asked us, any one of us, most of us 5 years back would have told OS is the gold standard. So now we are also accepting invasive disease-free survival in breast cancer also has to be standard of care change. So are we changing as oncologists, and are our goals changing? My answer will be yes, it is changing. So that is one fact why we are even discussing ADAURA today, that without OS data, can ADAURA be accepted? So if that is acceptable, otherwise the gold standard, what we were taught, what even we were practicing, that's why none of us thought of Gefitinib whenever this came into the panel. Is there OS advantage? And that the question was no, it took over. So for me, yes, that is the reason why I never practiced Gefitinib. But if now my thought process is there, should I change my practice? Would I do my practice if these trials were published today? I probably would give to some of my patients.
Okay. So, Sahu, you have confused me. Long and short of it. Were you giving Gefitinib or were you not giving Gefitinib?
No. I didn't confuse. I told that our gold standards of treatment have changed. The goal initially, what we were classical telling was OS, but now we have accepted DFS, invasive disease survival of breast cancer, and the lesser goals to be okay for adjuvant treatment. I told
so
that.
you are saying
this is very important point actually Sahu makes.
Okay.
That our goals are changing, and you have to question again, are they being changed or are they changing naturally? Who's changing them? But
I will come to that. I will come to the DFS versus the OS debate, Nitesh. I'm just thinking about, so between placebo and Gefitinib was not really coming up in a big way. Although if you look at this, I mean, just look at this. Before this trial came, I mean, just look at this. So this trial, when was it published in 2017, the hazard ratio was 0.60 in an adjuvant setting. The OS data had not come at that time. Let's just leave at 2017. So Kumar, at 2017, when you were there, I mean, what would you do in Tata?
So, we were giving TKI where in a very select group of patients. Think about, we have N2 disease patients, multiple station. And if I can't give chemotherapy, then this is one option I used to talk to the patient. Run of the mill? No. And the important reason has been to see the curve. You have a standard arm, which is touching the baseline. When did we get a study? I remember only one study. And that is N2 disease, which I say NEGM paper, where you have a stage 2 and stage 3 patient. The curve of DFS touches the baseline. What it means? At 44, 43 months, everyone has failed.
Yeah.
In both chemotherapy arm and other arm both. That has been very unusual. So this is a very unusual curve. And that is what raises the issue regarding this study. And then what we suggest, that everyone failed by 48 months, but here by 48 months, you have 50% patient being alive. This is a bit unusual curve, and that is why acceptance, in spite of DFS being fair, not good, fair, it was not usually practiced. But I do concede there are other studies where DFS curve was far better than this.
Okay, fair. Amish, what would you do? Okay, Amish, I'll ask this question to you, since this is a very nice graph which I actually got. So, you asked this question to Kumar. What is the natural history of a patient with lung cancer who has undergone surgery? How many of your patients relapse? Any take on that, Amish?
I think I agree with Kumar's figure. 70 to 75% of patients relapse in the moment the word stage 3 comes.
Okay.
No, I'm very intrigued in stage 3A population, which ADAURA has taken, Ullas. Assuming that these patients relapse within 2 years, 50%, 19.4% was the median PFS in this study. Say, assuming 50% patients relapse within 2 years. What do? You look at the relapse pattern, whether CNS relapse is there or not. If you have a CNS relapse, the quality of life of the patient is doomed. You give SBRT or you do brain surgery, you do NGS, you do all those things. Of course, you do EGFR, and if you find that Osimertinib, you can give Osimertinib at that point of time. That is something what we have right now. Following which, again, then you will think of chemotherapy. Agar patient ko chemo immuno है तो उसको उल्लास बत्रा के पास जाना पड़ेगा. हमारे पास तो सिर्फ वो के पेशेंट आके रुक जाते हैं. So with that, what I feel, the biggest, Ullas, 1 minute, the biggest point about this study it changes the natural history in terms of quality of life.
Wait.
I just cannot
Amish,
ignore
wait.
this.
Just wait for 2 minutes. Just wait for 2 minutes. So I will show you, this is a very nice curve which I took from Soda et al. This was a statistical design. What they basically did was, if a patient has undergone surgery, all the stages of disease, stage 1 to stage 3, there's the first peak which basically come at 9 months. Then the relapse peak basically, because there are growth of the minimal residual cells, there are regrowth of the drug tolerant cells. So if you don't give treatment, the first peak comes as 9 to 10 months. Then what happens is you have a small second peak at 12 to 24 months. If you give chemotherapy, again the first peak is lesser. And if you look at this curve, this comes over there, and then the second peak basically comes over here. But if you give chemotherapy, the point over here is your first peak comes out at later, but you ultimately, once you stop the treatment, Kumar, I would like to have your comments on this. So, there was a question in the chat box about the cytostatic versus the cytocidal group. Does this curve basically told, will you give Gefitinib for somebody with stage 3A disease for 5 years? Why not? So post-chemotherapy.
So asking me, Ullas?
Yes, Kumar.
So at this moment, no. But yes, we have example. We have been giving tamoxifen and letrozole for 10 years. But that too, I'll say curve will be this curve will be a gold medalist if you compare with the curve of letrozole and tamoxifen. And a similar kind of endpoint. It is the meta-analysis which has shown the OS benefit. You take individual trials, they are all been PFS benefit. But having said that, we need to see that how long it goes, how long we are able to suppress, or are we really happy only with PFS? Will the 5 years or 7 years will give OS benefit? These are all conjecture, but your statement is right that in this trial also, after 3 years, people did started failing more in the means the failure in Osimertinib arm started happening a bit more after 3 years. So there is an issue regarding this drug being static or cidal, but that is again a semantic question. This will depend upon the data. Looks like it is static because patients do fail later, but this is also true that many of the static drugs looks like if you give a longer period, maybe the cells are taken care by some body immunity. We don't know that. But that will depend what happens after a few years.
So Prasad, what I wanted to ask you was comments on this. The TKIs are cytostatic drugs. They are not cidal drugs. That was a question which was put in the chat box. That's what the debate is. The moment you stop it for 2 years, the disease comes back. So is there a point, your comments upon this design?
I think the design was purely because of the logistics of giving Osimertinib for a longer duration. I don't see any other reason to take a 3-year duration.
Okay. So let's come to the ADAURA trial design. I have not yet asked Dr. Rafiqul till now. So Dr. Rafiqul, any questions about the clinical trial design? What do you think? Was it a well-conducted study, easy study, difficult study? How do you think it is?
Thank you very much for the question. Can you hear me?
Yes, we can, but there's some disturbance.
Okay. It's okay?
Yes, Dr. Rafiqul, please go on.
Okay. First of all, the Adjuvant trial is a very good one trial. Actually, my perspective
okay.
Treatment and clinical data on this very early stage.
Can the technical team please help with the quality of the audio sound? In the meantime, can I go to Dr. Sahu? Can somebody Yes, Sahu.
Yeah, for me, if I look at this study, the design was done very cleverly to make it a positive trial. They already had the backing of 3 or more studies where they had they knew that Gefitinib, which is much weaker than Osimertinib, had a DFS data of 0.5 to 0.6 already, multiple trials. So we look at the primary endpoint, the DFS were designed that it was considered superior if they were beyond 1.7 only. So it was considered that it will be a positive trial. I would be more interested, I have nothing against the design as such, because that's how the pharmas do the trials. I would have loved to see a third arm of a Gefitinib versus Osimertinib versus placebo. that could have answered a lot of questions. Even to third world countries, this question should have been answered.
So
That's
Sahu,
one.
Dr. Sahu, can I come on to that? You know, the moment they would have kept Gefitinib, that means Gefitinib would have been the standard of care. The point is, out of 8 panelists, only Dr. Kumar said he was giving in selected patients. The moment, so you wanted a three-arm design.
No. First. Let's come to the first question. First, the primary endpoint. My point is, with the DFS with the hazards of 0.7, it was a done deal. You look into all the Gefitinib, Erlotinib trials, everyone achieved that DFS and everyone achieved a better DFS than that. So it was a done deal. It was more like having the knowledge of it and then you design a trial. So that is what point number one. So I don't have anything against the trial, but if you look at it in retrospective, this was done because it was thought to be a positive trial. It would have been a positive trial. My main question comes to secondary endpoint, the OS. That will answer a lot of questions. Apart from that, I think the design is a very straightforward design. The other, we can discuss the designs one by one, but that is a major thing for me, that this one had the advantage of the knowledge of previous trials and they designed it to be a positive.
Okay, I'll ask Nitesh now. Nitesh, what do you think out of these two designs, which of them is a better design? Do you think everybody spoke about chemotherapy? So do you think it's time to say bye-bye to chemotherapy? Do you think this trial, ADAURA, if you have a patient tomorrow who says, I don't want chemotherapy, and do you think this is good enough? You don't want to give chemotherapy? This is good enough, the second trial design?
No, I think the first trial design would have been better, where chemotherapy was compulsory in the neoadjuvant or the adjuvant setting. I think that would not have differentiated in some ways, but that would have been better. But on the whole, I think the trial design was good. As was pointed out by Kumar, it was very practical. It is what, when you're sitting in the clinic, you were thinking. You had patients who cannot get chemotherapy after surgery for whatever reason. There are issues. There are patients who have to go back to very far off places. And so from a practicing oncologist point of view, it was a very good practical study where you need to address these issues. From a company's point of view, of course, they were trying to prove it. and someone's right. They played it smart, but then they all do. So did Gefitinib and a lot of them. They were not small companies, right? But they were not able to prove that. So I do think it was a good trial design. Prasad, but yes, surgery followed by chemo would have been a good option.
Prasad, what is your take on the design? Do you think the down design where you compare chemo versus TKI, what everybody was comparing before, do you think that is okay?
I think chemotherapy has to be there in the trial design for sure, because that is the only treatment which we know has improved survival. And if I think that chemotherapy arm, even in EGFR mutant patients, had a good outcome. So we can't take out chemotherapy from the trial design in lung cancer without doing the second study which you do, which you have suggested, which I think will not come. And regarding the Gefitinib as the control arm, I think your question is very valid, because if this trial is designed with primary endpoint as DFS, putting Gefitinib in the control arm would have made it more. We can say that we have a new drug, a second generation or third generation TKI, which has improved the DFS over the first generation TKI. I agree with that actually.
Okay. Amish, can you comment on this trial design, the ideal trial design in Indian setting? You do surgery, then you give chemotherapy and TKIs, the KN regimen, the Kumar Narona regimen, and then followed up with TKIs. I mean, what is there which stops us from doing this? Kumar is not smiling at the name of this regimen. I think Kumar has heard this before.
I think nothing stops us from doing. I agree with that arm. The most important thing, Ullas, what Kumar said, that till the time we see OS data of ADAURA, we have OS advantage of chemotherapy in these subgroup of patients. Until the time we prove that this benefit is nulled and void by Osimertinib in adjuvant setting, I think chemotherapy remains. Now you are combining chemotherapy and TKI both in adjuvant setting.
Yeah.
So you are going ahead by what the failures of the previous trial, and this is a smart thing as long as it's a clinical trial.
So Kumar, your take on this KN regimen in the adjuvant setting? And maybe give a short duration.
So, TKI short duration is an issue. It looks like what we have learned till now, all the data. Chemo plus TKI, not a bad idea, except a bit of a toxicity increase. Everyone will have a question about it. So I'm good with chemotherapy followed by TKI.
Okay. Okay, so let me ask Dr.
Can I add a question to that to Kumar?
Yes, sure.
What about VEGF inhibitor and chemotherapy followed by TKI? Because
I think
there seems to be some
Nitesh,
synergy there.
Nitesh, I will come to that. Bevacizumab was trial in the ECOG trial because a lot of questions that was a failure, although it was a DFS increase. So I think that is nobody is trying at present. Since I have only 20 minutes remaining, let me go to Prasad now. Prasad, I think you did answer a bit about the magic number of 3. Why was Gefitinib taken as magic number of 2? Why Osimertinib magic number of 3? Any takers on that?
I think Gefitinib was because 2 years was just taken, and then with Osimertinib, I think we know that most of the relapses happen in the first 3 years, and so keeping DFS as the primary endpoint and using 3 years this is to make the trial positive. That's what I feel.
Okay, Dr. Bhavesh, any thoughts on that?
As initially the Amish and Dr. Kumar Prabhash also discussed that point, and the magic number 3 is still confusing to clinicians also, that the point is very clear that once we stop the TKI, might be some of the patients will come back and recurrence. And again, if we restart the TKI, some of the patients will also respond. So at present, for my point of view, I am still have doubt what should be the ideal years or duration of adjuvant TKI. With this ADAURA trial, I will definitely give for 3 years, but I am still not clear whether 3 years or 5 years.
So this was a thing which I got from one of the editorials. They said why 2 years was taken for Gefitinib was because the median time for a recurrence of N1 disease was 1921 1 months. They did comment that maybe in the adjuvant Imatinib in the GIST trial, maybe that is why they took 3 years over there. That is why it was taken. I think the long and short answer of it is that, they wanted a trial early. They wanted a positive trial. And that is why the magic number of 3 was taken. There is no real science behind it. Nitesh, your comments?
I think it was also partly related to the metastatic setting and seeing that we had an average median control of 2 years. So they possibly added 1 more year to see if they can get a positive trial in DFS terms for at least 3 years.
Okay.
Ullas,
now let me
I think the budget they had, they could give only for 3 years.
Trust Dr. Babu to say that, sir.
Yeah.
Okay, Dr. Rafiqul, I hope your connection is okay. PET, CT and MRI were not mandatory. Could this have impacted the results?
Hello, can you hear me right now?
Yes, definitely, yes.
Okay, thank you. Last question I just missed.
No, sure. So the PET, CT and MRI brain were not mandatory. In Bangladesh, do you always do a PET, CT and MRI brain before you go ahead a patient for surgery, or the real world practice is different?
Hello.
Okay. Let me go to Dr. Sudeep. Sudeep?
Yeah.
Whole body MRI is very famous in Nepal nowadays. Since the dye runs out of when
PET scan,
the COVID cases come.
No, if there's no PET scan, there's only alternative we have. Right. Right.
So you think a PET, CT and MRI were not mandatory. Did it impact the results?
Yeah, I think it should, because having no
Paras bhai, ek meeting mein
MRI, then we might be missing out the we might be missing out the disease.
True that. And, I mean, again, very, very important. I mean, this was a commentary by Howard West, and he said that, maybe there were a lot of occult stage 4 diseases in which you got surgery done. Osimertinib is a potent inhibitor of EGFR TKI. It kills the small volume cells more properly. So maybe that was, it was a factor that is why this was not there. Dr. Babu, sir, increased rate of relapses in the standard of care arm. This was
Ullas, 1 point just. Do you have data on how many had effect on MRI?
They have not given.
Mandatory.
They have not given.
So till we have that data, can you answer this well? But did it impact?
So that is what, sir. This was my 4th question. Actually, rate of CNS medicine patient who went MRI, VNet staging or PET scan. This data is not yet available. So we don't know. We don't know actually. Again, sir, Dr.
Do you think you will get the data? I'm not sure.
I don't know for myself.
Yeah.
So a question about chemotherapy, sir. How many patients of your stage 1, stage 2, stage 3 take chemotherapy? Is the thing similar?
Yeah, very similar. But again, I think here you're mixing up stage 1, 2, and 3A. So I think we need to break up that and see the relapses in each one. I'm sure it will be much more in 3A. So I think you cannot club all of them together.
Okay, fair enough.
But most of the patients are taking chemotherapy.
Yeah, no, I'm talking of the relapses that are occurring. It will be definitely more in 3A. So we need to look at each subset there.
Okay, so let's come to the meat of the matter. There was the results, the DFS in stage 1B, stage 2, stage 3A, the HR ratio of 0.12 that Amish kept on saying gaga over it. DFS in this and the DFS across the population, everything was, I mean, to me, very impressive. Prasad, impressive or not?
Very impressive, no doubt.
Very impressive.
I think the first look is like the first slide of yours, and when we go into the details, it is we are discussing. Yeah.
Okay, so the results were, I think everybody will say that the results were very, very impressive. Now let's come to the DFS versus the OS dilemma, and I'll ask you all about this basically. So can you give me, I think Prasad, I'll ask Prasad to speak for the DFS. Why should we give DFS as a primary endpoint in the study? And I'll ask Dr. Sahu to say why OS should be there. Is that a fair point, Prasad?
It's fine. So DFS is important because failure in lung cancer patients is symptomatic, painful, and it's not as if it is very easy to live with disease. We discussed this, and I think keeping DFS as an endpoint is fine in this setting. And
okay.
OS, we all
OS. I think Prasad, let Dr. Sahu say about this. You just tell about DFS and let Dr. Govind Babu be the judge of that.
It's acceptable because of the pattern of relapses in lung cancer patients.
Okay, so DFS in breast cancer is good, Dr. Prasad? I'm just putting you on a sticky wicket.
For all.
I'm just asking you to do a self-goal.
Yeah.
Okay. Dr. Bhavesh, DFS is good enough for you?
I think with this ADAURA trial, and we had discussed in also this webinar particularly also, I had now definitely practice changing, or we all oncologists should have open mind, or that means definitely DFS should be our change of the goal, and we should, as far as the lung cancer is concerned, I am clear.
Next election, no, Dr. Bhavesh, we have 3 Gujaratis coming up, I'm sure. And Modi and Shah are only the number 2 and number 3. I'm 100% sure of that.
Bhavesh is number 1.
Definitely. Nitesh, DFS good enough?
Not straightforward question. It's a patient-to-patient dependent. You cannot answer just DFS OS. On whole, I think I agree with Prasad that with a bad disease, I would accept it. But with the magnitude of benefit. So it's not just DFS versus OS.
Okay. So I actually thought, Dr. Sahu, you have been a critic of this.
Okay. See, if I have to debate it on that way, I feel there are points against DFS also in this, because we have multiple trials in this setting, at least showing that they have a DFS, which is very significant. 0.6, not a small number. 0.2 looks a much better number, and all of them failed on OS because it has been shown that TKI after the failure does catch up, and the OS does not. The OS advantage is lost. And second thing is the cost also incurred. You just cannot take away the cost which a person incurs with 3 years of adjuvant Osimertinib. So with that put together, it's not as straightforward that with the DFS, will I discuss? Yes. Will I just change my practice? I will still probably wait for the OS.
So let me ask Dr. Kumar. Kumar, are we actually lowering the bar? Did Donald Trump just lower the bar a bit more? I mean, somebody from Tata, we always think that this is the bar. I mean, people like me coming and doing things is not right. So are we lowering the bar by putting DFS as a primary endpoint? What is your take on that?
So, DFS, we have when we have a DFS data, there is the connotation to it. One is first, that is a DFS in that setting validated for OS, and that is where you don't argue much and we wait for OS data, but we accept it. Second is what is the quantum of DFS benefit? We also had sunitinib in kidney cancer. In spite of for DFS a positive study, we also look for what happened to pazopanib. In spite of 1 year difference, by and large, we have not used it. In spite of NCCN recommending it as one of the treatment options, because the quantum of benefit and side effects were somehow stacked in a way that we used to avoid using it. So second part again becomes important in the context of when we want to talk about what drug and what benefit and the quantum of benefit. That is the two aspects which is important to look into when we look for it. I'll give you another example for it, and again in adjuvant setting. For seminomas and NSGCT, we do have in early stage of them surveillance as a treatment option. So what happens if your patient fails? What kind of options you have? If you have options, in spite of randomized trial being between RT versus chemotherapy in seminoma, surveillance remains as an option today also in NCCN. Because again, third issue comes in, if you have a failure, what kind of salvage you have? Now, these three decides how do we practice, and sure that will be true for this.
I think that's an excellent point, Dr. Kumar. Let me go to Nitesh. Nitesh, Amish just put a question in the chat box, and the Pacific trial also said that they said it shows a DFS advantage and now has shown OS advantage. My question is, that's the crux of the debate, is that you have two arms. In one way, you did surgery, chemo, TKI, then the patient relapses, then gets some kind of care, then death. Is it equal to patient gets surgery, chemo, relapses, then has Osimertinib, further treatment, death? So the crux of the debate right now is that is Osimertinib at relapse will kind of neutralize the benefits of adjuvant Osimertinib. This is what the crux of the matter is.
That's what we don't know. That's why we are debating that, right? We don't know that. If you know that, then the problem is solved.
So what is your take on that?
If it is, I personally feel that this relapse business is better because you give it to the most deserving person, and in same way, 3B, N2, all of these patients you would really choose for. That's why I'm saying the answer of DFS and OS is not that straightforward, but you cannot ignore the fact that this is a treatment option that's available on the cards now based on the DFS.
What about the Pacific trial? Do you think the simile between Dr. Sahu, simile between Pacific trial and the ADAURA trial is right? What Amish has said, because what I feel is that, my point is, if a patient relapses at stage 4, Osimertinib still will have a 80% response rate. But in a stage 3 patient who relapses after CT-RT, single agent immunotherapy has a response rate of only 45%. So is the simile all right? You can come in and then let Dr. Amish come out again.
No, I don't think they are two different settings. That's first thing. He has a point, but I would look at these two subsets very, very differently. And this is more of a targeted, where I have a target, and the target works. And why I'm talking of the DFS OS debate will continue till the ADAURA OS comes in is that if you look at the CTONG study, and there's a beautiful data, I don't know how many of us has looked into data, of patients who have been on a chemotherapy and then received Gefitinib or a targeted drug versus patients who have relapsed of chemotherapy and then have received something other than targeted drug, and patients who have just received chemotherapy. The survival has been from 76 months versus 40 versus 23 months.
Yep.
So what I meant to say is that this debate will rage on till the OS data comes, and if OS data comes to around the hazards of 0.8 or 0.9, and if it is statistically just significant, will we still be debating is the only thing. But so my point is that I think the OS data needs to be mature for us to talk.
Okay. So this is for you, Amish. What will you choose? Money, luck, or love? And you can choose only one, not all three.
No, even if you don't put that, Ullas, I just I can't fathom why so much of debate is going on, and a person like you is asking. I'm sure there is a reason. That's why you are asking this. Let me put the other way. You are counseling a patient of stage 3A in your clinic, and you say, boss, you have 75% chance that surgery or chemo के बाद you are going to relapse within 2 years. अभी तो सर्जरी तेरी हुई है, अभी तो तेरी कीमो होनी है, but 75% चांस है that you will relapse in 2 years. Versus Osimertinib का मेरे पास OS डेटा नहीं है, but there is a 90% chance that you will be alive and disease free at the end of 2 years. What would you choose?
So Dr. Amish, that is why I knew you will ask me this question. That is why I took an article from Precision and Cancer Medicine 2020. Now look at the B point. we are all presuming that, you know, the everybody is going to be at least C or maybe A. But what happens if osimertinib gets you a bad biology of the disease and the survival? Once you are done with osimertinib, the disease becomes bad. You don't know. See, the crux of the debate basically is the B panel over here. Dr. Babu, Dr. Govind Babu, what do you think? A, B, or C? What is going to come in this?
Ullas, you know, I think DFS is an important endpoint also. You know, the research that is going on in lung cancer today, I'm sure if a patient is disease-free for some time, I'm sure there will be something coming in soon. So I will not just wait for OS. I think immediate point is to give him the benefit of what is there. You know, most drugs have started in the metastatic setting, come to the adjuvant setting, and we have shown benefit. So I would definitely base this, that yes, DFS is important, because I'm confident that all our basic research workers and you guys who are doing all the new clinical trials will definitely come up with something when this patient relapses.
Okay. Prasad, what do you think is going to be A, B, or C curve as far as the ADAURA is concerned?
I think it is
Bhavesh bhai, 15 more
I
minutes.
don't want to guess. I'm still thinking about the chat box guess which Parikh sir wants us to do.
Okay, let me go ahead with this. So
Ullas, one other point I want to make is, you know, if you look at the BRAF mutation, the mutations in the early stage is different from late stages. So in the EGFR mutated one, we are actually lucky that there is the same mutation happening in early stage. So I think that also makes me feel that we should give the advantage of this mutation to be targeted early on, unlike in BRAF, where the mutations are different with each stage of the disease.
Fair enough. Nitesh, or let me go to Prasad. Prasad, the unblinding issue. Yes.
Any examples of B?
So no, sir. It's so we don't know. So it's a sir, because
hypothetical.
Example lena padega, Ullas. Meri first B dekhe. The moment I saw B, I was scared, yaar.
No. The point is
homework for Ullas.
So the point is there something about A and C also? That is why we're having this debate. There's nothing to say A or C also exists.
Yeah.
So maybe once the COVID goes off, Kumar, one debate. Come on. Let's have dying to have a in physical debate. Okay. The unblinding issue. Prasad, what did unblinding actually mean?
So unblinding issue, I mean, I also read about that once this study was discussed. I mean, the change of the slide from first shot to the next one. I mean, if the patients are unblinded and then majority would want to go to the osimertinib arm, we will never get the data on what would have been a survival difference which would have happened if the patient had not crossed over. So that is what the unblinding issue was here. And I believe that now the patients are still on the same arms, right?
Kumar, can I come in? Prasad, since only 5 minutes are remaining, Kumar, the patients were unblinded or the results were unblinded? Patients didn't know whether they were on placebo or this, right?
Yes. So when unblinding happens, they know the result, but finally patients were informed. But you know what happens in here? See, unblinding has different connotation. Here, the unblinding, what it would have done was only to statistically harm the study in the sense that what the sponsor was looking for it would have been other way around. And yes, now the bar has been raised for them, because now not only the patients know it, they are crossed over. So the mark for them has been raised. So looks like as far as here the blinding is concerned, it is no way it in any way suggests that unblinding led to positive study.
Yeah, so unblinding actually has raised the bar a bit higher actually.
Yes, the bar a bit higher. Again, don't get me wrong. I'm saying when harming the statistical, I'm saying not harming the patient. It has ended up helping the patient.
Okay, so this is the types of disease recurrence. I think Kumar did say that the loco-regional and the distant metastases also are coming down. CNS GFS in overall population is also difficult. A very quick question, Dr. Nitesh. How will you treat a patient, and Sahu, how will you treat a patient who progress on the osimertinib arm? Progression while on osimertinib, less than rapid fire, less than 6 months, 6 to 12 months, more than 12 months. Sahu.
Repeat biopsy, repeat biopsy, and then ABCD or chemotherapy.
ABCP after osimertinib or standard of care arm must be Nitesh's patient. Fantastic. Prasad, how will you treat?
Yeah, mostly chemotherapy.
Mostly chemotherapy. So aren't we all getting a new circle that you're trying to push chemotherapy earlier onto that? Okay, Sahu boss, how will you treat?
I think Nitesh, I'll go to Nitesh way, not that the protocol which you told, but I will do the mutation analysis and then take it from there.
Okay, and just in case we thought our job sucked while sitting in the webinar like this, there are much more worse jobs to do over here. Okay, very, very important. If Osimertinib is not available,
can I ask any one of you who are doing more lung cancer than me to one question? Look at the CTOM trial. The 18 months versus more than 18 months, the data, if you look at it, does tell that more than 18 months patient did well. Point number one. With that fact, can Kumar, you or anyone tell me that in an Indian scenario, does 3 years Gefitinib make sense? Because original Osimertinib is way out of question.
So that is what I asked Dr. Sahu, that if you have, okay, this is Sahu, NSCLC Adjuvant, this is Osimertinib, will you choose the first generation TKIs? So can I ask, Prasad is smiling on this. Prasad, please remember this is being recorded, okay?
Right. So no, I will not choose first generation TK.
Okay, you are a faithful guy to Osimertinib.
Absolutely.
Dr. Babu, what will you do, sir?
See, we don't have any data for first, second generation right now as compared to Osimertinib.
Sir, yes or no?
Yeah, if you are driven for the cost, yes, we can try this.
Sir,
okay.
Sir, what data sir, in the ADAURA trial and the trials we had, we just have both the trials saying that there's a DFS advantage.
Yeah.
The only thing is that we have an OS data for these trials. We don't have OS data for ADAURA. So, so at this point, both the DFS is positive.
So
the quantum of positivity is different.
Sahu, one second. Can I just say, I knew people will say this. And when it was only the CTOM trial in 2017, everybody except for Kumar said that, we will not.
I told the way we looked at the disease change. Okay. If we look at it, we have also accepted adjuvant.
Fine. Okay,
yeah, I think that was Sahu's important statement that he made. That our endpoints thinking.
Amish is trying to cut away my points. Dr. Sudeep.
Yeah, because we have to choose sometimes because we don't have.
Sudeep already said he will
we choose it.
Okay, Bhavesh bhai?
I will not give first generation TKI.
And the final word is Kumar's. Kumar.
So I did say that that in select patients I used to use and that remains by. And those select patients I did give the reasoning. But for coming to Sahu's comment, it will be good to see the DFS curve for CTOM and also for Osimertinib together. Why people are more comfortable with Osimertinib? That doesn't mean that doesn't have an issue. Osimertinib trial has its own issue, and that's the reason. So we as a human being, we also see proportions. And here the proportion is, fairly different, and that's the reason.
So boss, should I take it that it is Osimertinib or nothing, and Gefitinib doesn't come into the question?
I didn't say that. In fact, Ullas said the first. I was the only person,
no.
Okay, Sahu, wait. I think there's an expert at the end of it.
Let me go. No, sure. Sahu can have a different view than me. Why not? Okay. But only I said when the CTOM trial had come, in fact, before CTOM trial had come, I have argued about it more than once in many conferences that if I have a T3N2 disease, these patients' PFS is going to be 7-8 months or 9 months. These are the kind of PFS we are going to get. And that is where if I can't give chemotherapy, I do choose counsel the patient.
If you can give chemotherapy, then Dr. Kumar Prabhash?
Then usually I don't. But I do agree.
The point here is, yes. So what Dr. Kumar is saying, if you can give chemotherapy and then wait, and then it's either Osimertinib or nothing. If you can't give, then you may consider giving Gefitinib. Is that what you're saying, Dr. Kumar?
I do. Okay. And I do agree Sahu has his point. And
obviously, Sahu always has a point. So there were tolerability issues. Amish kept on saying about only 3%, 2% people diarrhea. But imagine, Amish, a grade 2 diarrhea also for 3 years is slightly in a higher way. So tolerability also is an issue. Uncommon rare, I think I'm not putting into it. So my point is pros and cons. Never before seen the DFS OS advantage. HR ratio is superb. CNS recurrence occurring only in 2% of this. It reduces the distant recurrences. There is still no OS advantage. Are we only dealing the inevitable? We don't know. Financial toxicity is obviously of a concern. Tolerability for 3 years. is obviously a concern. These are pros and cons that we have in my mind. What will you do on 13th April? We will talk about it later. So ADAURA trial for me, this picture is the one which is going to summarize whether you are a Will Smith fan on the left side or on the right side. And as I said before, there is one truth on the right, one truth on the left. Your truth is different from mine. With this, thank you. Being brilliant panelists, having a fantastic discussion, and waiting for the experts' comments. Thank you.
Thank you very much, Dr. Ullas. Okay, go ahead, Amish.
Yeah. Ullas, I have seen you talk about lung cancer for almost 10 years now. I have seen your talk about afatinib after jeftinib. I have seen your talk about osimertinib after afatinib and jeftinib. Flora trial आया उसके बाद भी ये सारे सवाल थे कि अगर osimertinib आप फर्स्ट में ही दे दोगे तो बाद में क्या करोगे? So the same questions are going to come, Ullas. My point is that let's look at the DFS and let's look at the pros and cons. And as Kumar said, I think most important person to decide is patient. But at least we have an option where we would delay the relapses, even if that's the worst case. Lekin agar B aaya, then there is a problem. I never thought of that scenario.
So Amish, when you told me to do this, you told me to, I can't again say the words. So, thank you.
Correct. But I am sure 95% chance that A and C scenario would be there. In both the cases, I'm quite comfortable with Adjuvant osimertinib. But over to Parikh sir. Sorry for that.
आज के वेबिनार में जो प्रेजेंट है उसके किसी के पास भी सेटिंग नहीं आएगा.
Thank you very much. Thank you very much, Ullas. I put on the chat box also, and I would like everybody to understand that currently there are statistical methods available to factor in the effect of subsequent therapy. And I think we should be cognizant of that so that, we take away this discussion that what is the impact on overall survival of subsequent therapy that nobody can actually estimate. Fact is that such statistical methods are currently available. There is a URL in the chat box. We request everybody to just briefly answer. It will take you less than 15 seconds to do that. I would also remind everybody that now that we have achieved 6 months of oncology beyond the obvious, on 15th of next month, 15th of May, we are going to actually have a conference, and that will include 7 or 8 sessions that will look into further discussions and debates on what has been discussed so far on potential landmark trials. And it's a hybrid webinar, so all of you are welcome to come to Mumbai to attend it in person at your cost, of course, or you can attend it on Zoom. This would be extremely useful. Ullas, once more, thank you, and all the panelists for the very lively and heated discussions. I think it just shows to say how passionate we are to make sure that our patients have the maximum benefit and that we are doing the best based on the currently available data. With that, I now want to introduce to you Dr. Venkatraman Radhakrishnan, the professor and head of medical oncology at Cancer Institute, Adyar, a very dear friend, and he is going to have the tough task of giving the expert conclusion and the way forward for Wednesday morning in our clinics in the real world. Over to you, Venkatraman.
Thank you, Parikh sir. Thank you, Amish sir. A wonderful discussion by Kumar, Prabhash sir, and the panelists. Dr. Ullas, as usual, kept it lively and kept all of us focused. And I wouldn't say that I'm giving expert comments. I would say I'm giving my student comments or novice comments, because today I learned so much from the panelists and from the teachers here. So the interesting part is that, 10 years down the line, we had nothing in lung cancer. And today here we are sitting and, hair splitting one paper, with, finer details. That itself is a big achievement in the field of lung cancer, because there is hope for patients now. Patients are living longer. And the mere fact that we have come to, looking at DFS and OS, I think that's the victory for all of us at the end of the day. The next question is, will I change my practice? I would go with Dr. Kumar, Prabhash saying that I would individualize my treatment. in the setting where I work, definitely osimertinib is beyond the reach for almost 99% of the patients. That's why the financial toxicity comes. And it's also a big financial toxicity in the US as well. So if there is a generic osimertinib, yes, I would put my patients on this. But I won't ask my patients to sell their house to, start osimertinib. Let's not go into the other osimertinib which is available here. The next point I would like to say is that, the hazard ratio, everybody goes gaga about the hazard ratio of the ADAURA trial. But you have to understand that, hazard ratio only compares the two arms of the trial, and it is as good as the standard arm. And the survival in the standard arm was 44%. And even before the EGFR TK era, the survival in the LACE meta-analysis, I think, was about 59 or 60%. So did the standard arm underperform in this trial, because of which we are getting a hazard ratio? Look at the absolute benefit. Don't just go by the hazard ratio. So that is one more point I would say. So why, we don't know the reason why the standard arm did worse. Yeah, almost half of the patients, I think, didn't get chemotherapy. The next question which keeps on bugging people is that, I would not change treatment because I don't have OS data. But put yourself in the patient's shoes. Do we really deny a person treatment which has shown to work just because you don't have OS survival data and you have to wait for another 5-6 years and say, let's wait for 5-6 years and then decide? What if this trial shows a survival benefit? Aren't we guilty of denying somebody a treatment because we were too purist to say that no, adjuvant trials should have only OS data and not DFS data? If given a choice to a patient, if they say that, you take this drug for 3 years, and at the end of 3 years, there is 90% chance you won't get the disease back. And if you don't take a drug, you will have almost 40% only chance of disease getting back. I'm sure everybody would take the drug. So let's not go into the argument that OS data is not mature and therefore we should not be giving this drug. No. The NCI is doing the large Alchemist trial that's for both ALK rearranged patients with, I think, crizotinib and with osimertinib for EGFR mutant patients. So that's powered for OS. So let's wait for the Alchemist data as well to see whether this works or not. Yes, there were other flaws in the trial. Almost most of us have access to PET scans and MRIs. Had these patients had MRIs and PET scans, will it change the outcomes of this patient? We don't know, but let's appreciate that they managed to pull through such a big trial. And, let's not go into the nitty-gritty. My only concern is what happens in our country if we put a patient on OC and he relapses. We know that, if you put somebody on Gefnib, there's half the probability that he'll have a T790M mutation, you can put an OC. But after OC, you're going to get all your MET and, your KRAS and HER2 and all unknown mutations, and we don't have access to these drugs. And our patients don't have an access to make most of the clinical trials after they progress on osimertinib. So this is very unique to, resource limited settings. Do we delay a treatment which is curative for a longer time, let the patient relapse and then give him? Because we don't know. So example, 19 months is the median PFS in the standard arm. Suppose at 19 months he relapses and then we put him on osimertinib. The Flora data shows an overall survival of around 36 months. So 36 plus 19 is about 57 months. And here you have a patient who's on osimertinib who's going on surviving. So will the second line OS plus the first line PFS be still lower than what would we get if the patient is just on osimertinib? We don't know. We have to wait for the data. So yes, if the patient, I don't want to stand between you and the dinner. Yes, if the patient can afford osimertinib, I would put him on osimertinib based on the fabulous DFS data. If the patient can't afford, I may be tempted to give Gefnib, but again, Gefnib trials did not generate as much, jalsa, as they say, this as the as osimertinib managed to do. Had the same thing happened with Gefnib, maybe all of us have been putting in Gefnib. I think we need to have a trial where we need to head-to-head compare Aussie versus Gefnib, but I don't think any company would do it. Probably a big institution like Tata would do it. So I think that would be my closing points. And thank you all for this wonderful learning opportunity.
Thank you very much, Venkat. I think you nicely summarized what is the practical aspect of this data in the real world as of tomorrow. Once more, I remind everybody that 15th May is our 6th monthly Oncology Beyond the Obvious full-day conference from Mumbai. And I will hand over to Amish to have the final word.
Thank you so much, Kumar, Ullas, and everyone else. We learned so much today. Thank you so much. And please come or join on 15th of May. Thank you so much.
Bye-bye.